there was a brief conversation that you had on an episode of Truth Wanted recently that that kind of made me sit up and take note and brought a lot of curiosity to me, got us talking about some different ways of viewing, I suppose, gender in general and kind of human bodies and what we should or should not, or whether should is even the appropriate term for the way that we look at these sorts of things. So let's take a look at that clip and maybe jump off from there.
But there's a notion that has existed for years that people can feel that their gender is not consistent with their anatomy or their outward appearance. Do you agree that that exists, that there is such a thing as a dysphoria, people feeling like what they feel they are inside is not compatible with what they are on the outside?
I believe people can feel that way, but I don't believe that just because people.
Okay, stop. Okay, so you believe that people feel that way. Now, from a medical perspective, that's a problem, right? Because people are feeling bad, and it's our job as a society, and more tightly from my perspective as a healthcare provider, to try to fix that. So what's the best solution? The best solution, based on the science, and student Dr. Ben, who was on the clip show last week, said this very well. The best thing that we know how to do to help these people manage their gender dysphoria is to support their transition. You know, even if you wanted to call it a mental illness, it doesn't matter, because it's all about treatment and distress. So if you want to say that, like, whatever you want to label it, the appropriate thing to do is to support people in their transition. Like, period. Otherwise, you're not doing them any favors. And frankly, all this you don't believe in the existence of someone being transgender is just labels again. So if you say that you agree that people can have gender dysphoria, which is causing them distress, then they should be entitled, should they not, to seek care in the same way that someone having a heart attack is entitled to seek care for their heart attack, right?
You cannot compare a heart attack with mental illness. One is
why? Oh, hang on. Is mental illness? Let's put this gender thing aside for a second. Is mental illness somehow different from illness otherwise?
Mental illness. Look, gender is not gender.
No.
Gender is not.
Answer my question. Is depression different from Crohn's disease? Fundamentally, as a disease process.
I don't see what it has to do with it.
What it has to do with it is mental illness is illness. Okay, there is no difference between mental illness and illness. Okay. Anyone who has an illness, be it mental or otherwise, has the right to seek care for it and should be offered the appropriate care for it. And when it comes to someone who's experiencing what we understand as being gender dysphoria, they have the right to seek the appropriate care, which we know from all of our scientific studies is a support through a transition, which includes things like hormone therapy and surgery, gender affirming surgery. So where's the problem?
You cannot compare a heart attack with gender dysphoria. It's in your
Why?
Listening. Okay. Well,
what's the difference?
If someone thinks that they're a dog, does that mean if someone feels strong that they're a dog, does that mean we should let them behave like dogs? If a child thinks they're a bird,
if we have science to back up that is the best way to approach their specific problem, then yes. If you want to be humanitarian about things.
So you're telling me it's okay to let a child act like a bird and then jump off the roof, try to fly, and jump.
We have evidence that it's the best thing for that person, then yes.
All right. Well, there's a lot to unpack there. I know that we trimmed that clip down a little bit, and James ended up hanging up before you were able to really walk him through these things. I guess I want to start by just acknowledging the fact that you were pretty quick on your feet in tackling some very kind of drunken boxing style of dialogue, and then also note Shannon's very obvious desire to like pull back and not attack. So congratulations on the way y'all managed that call. But after the fact, is there anything that you would want to kind of add or maybe explain about your point of view here?
Yeah, so I think a lot of, obviously things are a little bit different when we have a call-in show and someone's calling and we don't really know where they're coming from, what their background is and stuff, right? So, sorry. So we obviously need to take different approaches with different people. And so I think when someone calls in and they are very recalcitrant to modern understandings of like transgenderism, then you have to take a little bit more of a practical approach. That's been my experience anyways. And so that's the approach that I've used in the past, is very focused on, problem and solution. And I think it's the easiest one potentially to argue because we have good medical evidence to support it, right? And so if you can get someone to acknowledge that there's a person suffering from gender dysphoria, and the way to alleviate that dysphoria is with a particular treatment, then they then have to justify why we shouldn't be applying that treatment. So that's been my general approach. And obviously it would be different if people were calling in with a different attitude and a different perspective and different understanding.
Sure. And I definitely hear that. And I am honestly really excited to kind of tease some of this apart because while I don't want to oversimplify things, what we're really looking at here is the question of whether or not being transgender inherently requires a level of distress, or whether that that issue or that concern of feeling like you are in the quote wrong body is like a necessary ingredient. And I think that that's a really interesting and important conversation for us as a society to be wrestling with. I don't even really mean to say answering, because even though we're going to be exploring some different models and some different ways of looking at it, I don't think it's at all fair to suggest that you or I could have a quote answer to that question. But there's a lot of really meaningful things to explore. So as we're getting into this, I guess I want to just acknowledge that we're going to be exploring some maybe philosophical themes, which is sort of a brash way for me to say that we're going to be talking about transgenderism in sort of an abstract way. And I can appreciate why that would be uncomfortable or triggering for a large percentage of our audience. So if you're watching this and this conversation feels uncomfortable or unnecessary for your mental health, thank you for being here. Thank you for being a part of our community and for watching the show. You are more than welcome to log off and do your own thing. We certainly, as two cis men, want to handle this conversation as kindly and as compassionately as possible. But if you feel like we've gotten it wrong, let us know. Please reach out. Please call in. Please do whatever you need to do in order to take care of yourself and in order to maybe have your point of view heard. But we're going to dive into it a little bit.
Yeah, I'm excited. I hope to get some new perspectives and learn as well tonight.
Yeah. Well, so that in mind, let's, I guess, kind of summarize the conversation so far, right?
Sure.
If we're looking at like ICD from the World Health Organization or the DSM from the American Psychological Association, both of those manuals have dramatically changed their understanding of trans bodies and trans needs in each of the last 3 editions. Can you kind of summarize for us a little bit the way that the medical establishment has evolved in their thinking over the past 50 years or so? I know that that's a big task, but if you can set the table for us a little bit, we can dive in from there.
Sure. So, I mean, I think the biggest change that I would point out is that when we moved from the DSM-4 TR to the DSM-5, the major change was that we moved from the diagnosis being gender identity disorder to gender dysphoria, which I think fundamentally represents a shift away from the pathologizing of the gender identity and towards a focus on the patient's experience and the person's experience.
Mm-hmm.
And I think, you know, the DSM has a sordid history of sort of pathologizing things that become problematic, right? Like, I don't remember when it was phased out, but at one point, homosexuality was classified as a mental illness according to the DSM, right?
Sure. Yeah,
And
that was
so,
in not the first two, but in the third edition, and then not in the fourth.
right.
But worth noting that for I think some 10 years there in the 70s, that was a classifiable mental illness, quote unquote.
Mm-hmm. Mm-hmm. And so obviously the DSM is not, gospel,
Sure.
so to speak, and it's evolving, and it's made by people and a large group of people who are experts in their field, but people all the same and can make mistakes. But I think that the change represents a shift in the way the medical establishment is understanding things, away from the focus on what a disease is on a fundamental note, and a focus towards how it affects patients. And I don't know, maybe we can get into it later after we've gone through some of the other stuff, but I
Sure.
think this reflects a change in the way that medicine overall is discussing all pathology and not just gender related pathology. So I'd be interested to talk about that as well.
Yeah, absolutely. I think a lot of this conversation, at least for me, kind of hinges on the way that the neurodiversity movement, in particular, has addressed the quote unquote question of autism. I don't want to overly simplify the neurodiversity model, and I also don't want to overly conflate it with some of the conversations that we're having tonight. But very briefly, to maybe set the table for folks, at least in the way I think about these issues, when I think about being transgender, I think about it in terms of a natural human diversity. The idea that human beings are going to be genetically and environmentally and in the way that we express ourselves, like phenotypically, going to be just naturally diverse in a number of ways, and that we're not going to fit into discrete boxes in a large number of occasions. The neurodiversity movement in particular has worked to say being ADHD or having autism or being autistic, depending on your framework and some of the language that we use, that these things are not illnesses. They're just simply different ways of being. And any disease aspect that we might ascribe to something like having struggles with reading or having struggles with sensory processing or some of these things are not so much diseases in and of themselves as they are being left-handed in a right-handed world, or trying to exist in a cultural framework that was built towards a majority that doesn't necessarily properly capture all of the diversity and all of the intricacies of being a human being. That's something similar to the model that I tend to use when I think about being transgender. But of course, all of this is made up, right? All of this is just a conceptual framework created by humans to try and describe our world, and it's imperfect and it doesn't capture everybody. And so looking at some of those models and trying to understand how we can maybe better explore and know what it means to be a human is sort of what we're here to do tonight. So I'm hoping that you can, in brief, maybe try to summarize for us what we might call the medical model, or perhaps sometimes people use the term distress model or pathology model. Those three things might even be separate, but for the purposes of our conversation, how can you maybe define some of those ideas for us?
Sure. So I'll start by adding the caveat that I'm not a psychiatrist. I'm a
Sure.
medical doctor, and I've done research in cancer. So this is not my area of subspecialization.
Hmm.
But I've done, obviously rotations in psychiatry, and had to treat patients from a surgical perspective who were trans. And so I have that sort of experience, and I think it perhaps represents how doctors who are coming out of training today, your average doctor who's not a trans care specialist, would understand things. And I actually think it's not too different from sort of the neurodiversity model that you were describing a few moments ago. Um, the old school is very focused on the pathology. And so it's often a binary. It's a yes or no. Do you have these qualities? Do you portray these, in a mental health, diagnosis, there will be a bunch of hallmarks of a particular mental illness.
Symptoms, right? If we're
Symptoms,
being frank,
essentially
yeah.
symptoms. Yeah. And, the old school would say, if you have those symptoms, then you meet this, this criteria, this diagnosis, and you're into that box. The modern understanding, and you'll see in the DSM-5, and I think even in the DSM-4 TR it was, there's, a bunch of criteria, and they're listed like A1, and the symptoms are under A, and it's 1, 2, 3, 4, 5, 6. Then if you go to B, it says, and it's causing interference with your daily function, affecting your life, causing you distress, that sort of thing. And so I think that's really representative of how modern doctors approach all disease, and not just mental health. Is it a clinical problem in that it's affecting your function, it's affecting my patient's well-being, and as a result, we need to do something about it to help them? Or is it subclinical? In which case, we don't need to do anything. They don't meet a diagnosis, right? They're just a person who has a particular, as you said, they're maybe not falling into the majority norm of your standard curve for whatever characteristic you're talking about, but it's not affecting them, so we don't have to do anything about it.
Yeah, that
so
term
we purposely don't pathologize those people.
Exactly. Yeah, that term subclinical, I think, is a sticky wicket. It is complicated in a lot of ways. But without wanting to get like too deep into it, I guess I just want to say that I will watch TV, and they will sort of reference the DSM, and they'll sometimes call it like the Bible of being a therapist and these different things. And the truth is, as a counselor, I'm not maybe representative of everybody, but I use the DSM 95% of the time to help sort of show somebody that they don't have the condition that they just diagnosed themselves with from
Right.
WebMD or something along those lines. Like, I'm not using the DSM in that way, because if we're being honest, the DSM, at least in my opinion or in my experience, is mostly about proving that your problem is bad enough that an insurance company should be obligated to help you pay for treatment regarding it. That's certainly not the only purpose of the DSM, but this is something that is largely created so that insurance companies have a frame of reference, and it's not oriented towards like wellness or what we might call positive psychology so much as it is like highlighting areas of distress, highlighting things that are going wrong. Because for a insurance company to pay for your problem, you need to demonstrate that it's causing an issue. Is that a fair framework?
I mean, it's a little bit different from me because I work in practice in Canada, where we don't have to deal with difficult insurance companies per se. We have the government is our insurer.
Mm-hmm.
And so they have, a list of criteria or a list of conditions that they'll cover. And so certainly the DSM is used by them to decide what constitutes a problem that they then have to cover through their insurance. But I don't think it started that way. And obviously it's the American Psychological Association.
Sure.
So it's fundamentally based in the US. But I think it started fundamentally as a way for doctors and psychologists to try to organize people to figure out how to study mental illness and how to treat it. Because that is, I think, the basis for a lot of medicine is, it's all patterns. And as you say, there is a diversity even within, I'll use an example of like appendicitis, which is something I treat a lot of, right? It's inflammation of the appendix, and people present differently. They can look totally different. A lot of them look the same. Again, we've got like a general pattern that comes up very frequently, but people
that term
deviate
diagnostic and statistical is meaningful. Like we tend to just summarize DSM, and those words start to lose their meaning. But it's worth remembering that we are talking about how people stereotypically or are statistically likely to present.
Right, and those classifications are useful mostly for research purposes and to a certain degree for treatment purposes historically.
Because there's a predictive value in that sense.
Right, exactly. And I think that that's probably how the DSM started and was intentioned, right? They wanted to put people into boxes so they could say, well, what works for this condition? We can't try every remedy under the sun for each person. So we try to group people together so we have enough statistical power and can draw some real scientific conclusions about what works best for them.
So it's certainly not a perfect model, and I think that people working in the field largely recognize that, even if we don't always remember it on a day-to-day basis. But from the outside, I think it's really important, MD, for folks like you and I to try and communicate to the people who are watching shows like this that when you work in the field, these labels, these diagnostic labels, these books are imperfect, and we don't expect them to be quote unquote right so much as just a guideline or a way of understanding things. And so to that end, I want to, I guess, just very briefly and maybe even like criminally under explain a couple of other models when we're talking particularly about gender and about transgender healthcare. The first is what is known as the interactional model, which I want to really recognize for the audience I am under summarizing, and that you could probably do well to explore or read about for yourself. But the interactional model of gender is, roughly speaking, the belief system that gender is a form of expression, and therefore it relies on sort of our looking glass self. It relies on the way that people interact with our gender. That if you were living on a deserted island by yourself, you might not even, quote, have a gender, except that even on that island, you're going to be there also experiencing yourself and experiencing your gender. So all gender is sort of defined through the idea of expression, how you explain yourself to other people, and then how they react to it. So in that lens, or from that point of view, your gender couldn't possibly have a distress component except for the ways in which your body or your experience of yourself doesn't line up with the way that you feel that it should, or in the ways that other people experience you don't code correctly from a certain point of view. If you express to somebody, I am a man, and they don't see you as a man, that would be transgender or transgender distress or gender dysphoria, depending on exactly how you look at it. And then next to that, I might put the informed consent model, which is basically an idea around bodily autonomy. That when we're talking about things like hormone replacement therapies, when we're talking about gender confirmation surgeries and some of these other ideas, the informed consent model might express, hey, it doesn't matter if I am a man or a woman or whatever else. It doesn't matter if you think that I am a man or a woman or an NB person or anything else. I have bodily autonomy and the right to make my own healthcare decisions, ergo vis-a-vis concordantly, I have the right to take testosterone. I have the right to be prescribed estrogen, or I have the right to change or manage my body and the way that it expresses itself on my own. With all of that being said, all of these different models, all these different frameworks that we're just kind of like throwing out into the ether, I'm curious, MD, what you in like very human terms, how you as a cisgender physician understand the medical needs of trans folks.
Yeah, so I think that that's a really good question, and I think it draws the appropriate distinction between, you know, the interactional model that you were talking about and sort of the medical model, we can call it. Physicians are predominantly concerned about problems and solutions. We're basically like human body mechanics, and I say this as like a surgeon, so I especially consider myself kind of like a plumber of the human body.
Mm-hmm.
And so I think that, you know, the interactional model I actually agree with, and to a certain degree I also agree with the informed consent model. I think there are some issues with it that we can get into, but like, so with the interactional model, correct me if I'm wrong, you would say that like if someone lives in isolation, they don't necessarily have a gender per se in the way that we would understand it, in the way that we understand it currently, right?
Yes and no. This is maybe a complex idea and maybe more philosophical than medical, and not super falsifiable. But for myself as a therapist, I operate in a lot of framework that sort of depends on the looking glass self, or the way that we experience ourselves, which is to say, I guess to simplify, if you are angry at your mom, for instance, it would be useful for you to be able to hear an apology from her, for you to like come to terms with that, for you to express why you're angry, and for her to apologize, and for you to give forgiveness. Like that would be a beautiful thing. But oftentimes when I work with a client on that type of anger, that's not an option. That's not an opportunity. Perhaps mom is just not willing to engage in that conversation. Perhaps mom is passed on, or in some other way unavailable. And so we can still do things in a therapeutic sense that would be like, for instance, writing a letter to your mother who has died, or having a conversation with an empty chair. And we can rely on those types of like mental models of your mother in order to explore those feelings. So when I think about gender, I think very much about the way that we have sort of control over our own fantasies, and we can sort of imagine these experiences. So in that sense, I really do believe that somebody on a deserted island by themselves still, quote, has a gender, even if it's going to be defined very differently. And that's going to be especially true of somebody in this, you know, thought experiment who never actually met anybody else. If you had a baby raised in isolation, their concept or their gender, I suppose, in that idea would be non-existent.
Right. If you ask them what their gender was, they wouldn't understand the question, essentially, right?
Right. Which, again, in this thought experiment, somehow they've learned English by themselves in isolation. But nevertheless, as long as we're playing with it.
Yeah. So, I mean, I think that that's not at all at odds with the medical model. I think that physicians in the medical model is predominantly concerned only with those people who require our care. And that's like really, you know, to put it bluntly, that's what we care about. And obviously trans care from a medical perspective still goes far beyond, you know, just providing hormones and surgery. So if I were a family physician, I would have to care about the mental health aspect of it that often accompanies clinical transgender patients, the discrimination they would face and the marginalization they would face, and how I could potentially help with that problem. But again, these are all problem-oriented things, because ideally, I want to never see my patients again because they don't need me, because I'm just a problem solver for them. I'm a mechanic. They come to me with a problem and I fix it, and then I don't want to see them again, because if I do, it means that I haven't done my job right. And so I think, the interactional model and the medical model are not necessarily at odds. It's just that the interactional model, I think, is much more broad and looks at all degrees of the trans spectrum and the gender spectrum, in terms of both the severity of any potential dysphoria or potential distress, whereas the medical model focuses only on those individuals who are distressed in some capacity.
Yeah, and it's probably worth pointing out that none of these models is, quote, correct or incorrect, but they are a different way of viewing things. I might think about it in terms of like bifocals versus telescopes versus microscopes, because as we discuss being transgender in 2022 North America, find me a trans person who has not experienced meaningful distress because of bigotry, because of like societal concerns,
right?
And I'll be blown away. So in our modern conceptualization, we almost always, or perhaps even exclusively, think about being trans in a almost pathological kind of lens. We assume that there's a level of distress, and perhaps that wouldn't be the case, or perhaps that doesn't need to be the case in a more egalitarian or perhaps utopian society.
Sure.
But I've never lived there. So my
Yeah.
concept of that is all fantasy at this point.
Right. And I agree. And I think that that's a good point, because I agree that I think a lot of the problems, like you raised with the neurodiversity movement, also applies to the gender spectrum as well, where a lot of the distress comes from the interactions with society. And, you can approach, again, as a problem solver, you can approach that distress in two ways. You can say, well, we need to help the person fit with the society, or we can say we need to make the society fit the people. And I think that one of those is much easier to do than the other, which is the one that we do, right? So we're practical in our approach to it, because I agree, ideally, we could just create, an egalitarian ideological society where people are accepted regardless of how they identify in every way. And they don't face any marginalization or barriers. But I think from a practical perspective, we can both acknowledge that we don't live in that world, and creating that world is certainly not going to happen probably within our lifetimes. And so I think it's important to have something like the medical model to enable us to help people who need it now, people who are suffering now. And that's, I think, really what the focus is focusing on the person, in the medical context, the patient in front of you, and what they're going through and how you can help them.
Well, and I don't want to be unfair about this question, but I'm just overwhelmed with curiosity. So I have to ask you about your thoughts on the informed consent model. Because on the one hand, I am somebody who wants to respect and believe in other people's bodily autonomy. On the other hand, and forgive me if this is like a shitty example, but I cannot get behind a model that would say, for instance, that it is okay for a bunch of QAnon supporters to have access to ivermectin. Any sort of model that allows people to make decisions about their own body in ways that are perhaps reckless, or that are not maybe informed to the degree that I would like them to be. I don't know if that could be seen as authoritarian, but I'm really curious as a physician what your perspective on that idea is.
Yeah, so the whole notion of like bodily autonomy has come a long way in the past probably 50 years. So my grandfather was an OB-GYN, and back when he was practicing, they practiced what's called a paternalistic model of medicine, which you may have heard that term before. But essentially it means the doctor is the keeper of the resources and the arbiter of diagnoses and treatments. And if the doctor says you take this, then you take that medication. And if the doctor says you don't get to have this operation, then you don't get to have the operation, and there's no discussion. Again, being like new school, we are very dialogue focused, and we practice what's called patient-centered care, or at least we try to. And that gives a lot more autonomy to the patient. So a lot of the discussions I have with patients, instead of me saying, this is the treatment, I say, well, here are the options. Here's what we know about the options. Here's the one that I think works the best in my medical opinion. And that's the one that I would recommend, but it's up to you. And, these discussions are often grounded in a conversation about the patient's values. So I'll give you an example. One of the things that I talk about a lot is end of life. I take care of a lot of sick patients in the intensive care unit. And so there are discussions that we have, usually not with the patients, but with their families, about whether or not we should withdraw life-sustaining treatment. And how those conversations always start is, tell me about your loved one. Tell me about your father, your mother, your daughter, whoever. What would they like? What are their values? What do you think they would want for themselves if they were, able to make this decision? And we get to know them. And based on that knowledge, based on an assessment of what the patient's values are, then we will lay out the options and recommend a treatment. And so this is the new autonomy that we try to give to patients. And although we try to give autonomy to patients, it has limits, which I think is where you're starting to come from with your objections to the informed consent model, which I agree with.
So it is somewhat blended. Like you can't do exclusively one or the other, at least in your opinion. Yeah.
Well, I think you can't, in my opinion, and I don't think you can practically either. Right. And I also don't think it's a good idea to do it. So another classic example is parents will come in with their children who have an ear infection, and you assess it and it looks like a viral ear infection, and they will demand antibiotics. And there's a lot of scientific reasons why it's not a good idea to give out antibiotics like candy. The most important one, so number one, it won't work to cure a viral infection, right?
Right.
That goes back to your ivermectin and COVID example, right? Ivermectin as like an antiparasitic will not help COVID, will not treat COVID, and antibiotics won't treat a viral infection, but they'll also contribute to the development of superbacteria and things like this, right?
Right.
So obviously, you can't have 100% autonomy. You can't allow that, and I mean the most distressing examples and the most extreme examples are, again, patients I see who come in and they potentially, they've done some sort of self-surgery or something like that to themselves. And it's usually for an underlying reason of mental health. There's this notion of, give me a second to look it up here. I lost it. There's a particular mental illness where a person can, as part of their identity, they believe that they're, for instance, disabled when their body is not disabled.
Sure.
And so they will seek to align their body with their internal identity, right? And so sometimes that means they want you to amputate a limb when it's not medically called for, or perform a spinal transection to make them a quadriplegic or a paraplegic or something like that. And in those cases, we don't facilitate that sort of identity affirming care, as you might say, because there's no good evidence that that's going to help their problem. And in some cases, there's evidence that it is detrimental, that their problem persists after this happens, in patients who don't necessarily get it done by a medical professional, but do it themselves and then come afterwards to the hospital to seek, post-trauma care or post-operation care. And so I think that there's problems from that perspective with just enabling anyone to do whatever they want. And there's also resource problems, right? We simply can't afford, as people who live in a universe of finite resources, we don't have the resources to give everyone all of the care that they want. And so we have to base our decisions on allocation of medical care, for example, based on the resources that we have and how best to use them.
Yeah, so ultimately, it isn't just a like community health problem, like in the superbug antibiotic for antivirals example, but there's also something that I guess as an outsider I'll refer to as like a Hippocratic oath problem of causing distress or allowing somebody to come to harm because of your medical intervention, even if it is at their request. Yeah.
Right, exactly. And I mean, that's the big, I think one of the big debates that people have currently. Some of the, again, older school surgeons who don't necessarily believe the research on gender affirming surgery will say, I'm not going to do that surgery. And then you get into this question of autonomy, right? Whose autonomy trumps whose? Does the patient have the right to force the surgeon to perform a procedure that the surgeon doesn't want to do? Does the patient have the right to force a medical professional to prescribe medication that they don't want to prescribe? So there are a lot of predominantly Christian physicians who refuse to provide like birth control or abortion care. And the way that we've gotten around it here in Canada is that physicians have a duty to refer. So they don't have to provide the care, but they have to refer the patient to someone who will provide the care. Of course, the question then becomes, what do you do if no physician is going to provide the care that you want?
Yeah, well, I'll tell you what. I was actually briefly expelled during my graduate studies because of my attendance at a Christian university and my sort of aggressive stance on the appropriateness of counselors referring people out because of their orientation or their identity as homosexual. So there is a lot to play with here. I'm really appreciating this conversation. But before we get any deeper into it, let's take a quick moment